Today's lecture will be part one of the cardiovascular system review. Today we'll start off by looking at some of the functional elements of the cardiovascular system, then we'll move on and look at some of the main differences between the pediatric and the adult cardiovascular systems and their importance. And then we'll look at some of the more common cardiovascular disorders, specifically hypertension, angina. We'll look at myocardial infarction and then talk about congestive heart failure. We'll also look at some of the how cardiovascular diseases kind of morph and progress. And then we'll wrap up by looking at some of the common drug therapies involved in managing these cardiovascular diseases. So let's start off by looking at the functional elements of the cardiovascular system. As you can see, this is kind of a simplified a way to think about the cardiovascular system, but essentially what we have is a fluid system where we need to move that fluid around. So we've got a pump that's able to push the fluid around. We've got our conduits or pipes through which the fluid's going to flow. We also have mechanisms in place to help modify or regulate the pressure and the volume of the fluid. And then we also use that fluid to not only move, dissolve things, elements through around the system, but also as a means of exchanging supply and supplying fresh gas to the system as well. And so if we kind of look at how those different functional elements correlate with the anatomic structures, you can see obviously we've got the blood as the fluid, we've got the heart as our pump, the blood vessels, we've got the kidneys and the vascular smooth muscle that help regulate not only volume but also pressure, and then certainly our lungs are the sites of gas supply and exchange. And then what's interesting is the pump actually has a mechanism in place to provide that fluid that it pushes around back to itself, and those are the coronary arteries. So once again, the kind of simplified version here is that we've got a simplified pump, and that pump generates pressure to drive the fluid around. That pressure is continuously adjusted to make sure that we maintain a continual movement of that fluid. We've got oxygen that's exchanged under that pressure, and then the pump that provides the pressure is fed or metabolistically driven by the oxygen that it pushes around through the fluid. Now, in terms of the control mechanisms that are in place for managing the blood pressure, there's a variety of different system-wide control mechanisms. We can see the autonomic nervous system plays a role, as well as the angiotensin, the renin-angiotensin-aldosterone system, and then finally the endocrine system. And all these are the three main mechanisms that help regulate blood pressure. And we'll kind of look at each of these in detail. So the autonomic nervous system, we'll start with that one. It really primarily provides beat-by-beat control. It does so, as we've mentioned in other lectures, via this kind of idea of dual regulation. And so you can see this diagram here. It's very busy, but one of the things I want to point out is let's look at the heart in particular, and you can see that we've got innervations from both the sympathetic and the parasympathetic sides. So we have that dual regulation that provides kind of this balancing act. Where we can see, upregulation of the sympathetic and downregulation of the parasympathetic, and then back to the other way. So we kind of have a teeter-totter effect. Now, that dual innervation affects both the heart and also the blood vessels. Now, the activities that both of those sympathetic nervous or parasympathetic nervous systems can provide in terms of the elements it can change with relation to the heart, we can see alterations of the heart rate and also the contractility. We can see with the blood vessels, we're going to basically regulate either the degree of vasodilation or vasoconstriction. And all those kind of pointed together will help regulate and provide a nice constant, that's really our goal is to provide a nice constant mean arterial pressure. So we're continually moving that blood or that fluid around through the periphery. Now, if we look at the renin-angiotensin-aldosterone system, this particular feedback system essentially is tasked once again with maintaining blood pressure. It's mainly turned on when we have hypotensive or systemic hypotension, and the renal effects that we see from turning on this system, essentially what we see is vasoconstriction, which is triggered by the release of the angiotensin, and then we see sodium retention as well. And that's primarily done via the aldosterone that's released. So essentially with this mechanism, what we have is blood pressure, hypotensive blood pressure, so blood pressure kind of drops, and then that is sensed in the macula densa part of the renal cells in the glomerulus. And essentially what that causes is a release of renin. And the renin is released, and that triggers the conversion of angiotensinogen into angiotensin 1. Angiotensin 1 is then further converted into an active form, angiotensin 2, and that conversion is done by angiotensin converting enzyme, which is where your ACE inhibitors have an effect. Now, angiotensin 2 does two things. It acts as primarily as a potent vasoconstrictor, which is inherently going to help resolve the hypotension by causing vasoconstriction. But it also does another thing. Angiotensin 2 also triggers the release of aldosterone from the adrenal glands. And the aldosterone, once it's released, is going to act on the kidney to increase the sodium reabsorption or retention, which is also then going to promote retention of water. And that increase in volume is also going to help combat the hypotension as well. So you can see that we have two effects here going on. We also have the vasoconstriction and the sodium retention, which leads to an increase in volume in fluid volume. And the endocrine system is also involved. We can see that it's triggered as well by hypotension. And what we see instead here is the release of vasopressin, otherwise known as antidiuretic hormone. And ADH or vasopressin causes water retention, and it does so by acting at the aquaporins, and it's going to promote the reabsorption of water molecules in the kidney, which is once again going to increase the volume in the systemic vascularity. By increasing the volume, that's going to help raise the blood pressure. Additionally, vasopressin has another role as well. In addition to increasing blood volume, it also acts as a direct-acting vasoconstrictor as well. So we get kind of a 2-for-1 deal here. With vasopressin, we get increased vasoconstriction as well as promoting the reabsorption of water, which will help increase the blood volume. And both of those together are going to lead to an increase in arterial pressure. Now let's move on and look at some of the comparisons between the adult and pediatric circulatory systems. With the adult circulatory system, once again, the main goal that we have in terms of the job of the circulatory system is to maintain constant perfusion to the body. And it does so by balancing the two main factors here. We balance the peripheral vascular resistance along with the cardiac output. So the peripheral vascular resistance, that's your systemic vascular resistance. Remember, that's going to be your vasoconstriction versus vasodilation, that kind of balance between the two. And then our cardiac output, which is a combination of the rate times the stroke volume. And so in order to alter the cardiac output, we can do a couple different things. We can either alter the rate. Remember, you've got your baseline rate, which is going to be impacted by the autonomic nervous system in terms of, sympathetic nervous system is going to increase the heart rate or decrease the heart rate. We can also increase or decrease the conduction velocity. So remember, the SA node can be impacted by the sympathetic or parasympathetic nervous system, and it can alter the inherent rate of depolarization, and we can also increase or decrease the rate of conduction along the electrical conduction system of the heart. We can also alter the stroke volume, and we do that by altering the contractility, essentially altering the strength at which the cardiac muscle can contract and squeeze. Now, if we look at the pediatric circulatory system, we see that the goal is pretty much the same. We want to maintain perfusion to the body. And once again, we have that balance between the peripheral vascular resistance and the cardiac output. But the big difference here is with the pediatric circulatory system, you can see that pediatric patients don't have that ability to alter the contractility. Essentially, they can't make their heart squeeze more strongly. So the only thing that they can do in terms of cardiac output, essentially, is to alter the rate. And so that's one of the big differences between pediatrics and adults, is that pediatrics, the heart rate is essentially very, very crucial, because if we see a drop in heart rate, we know that we don't get that compensatory increase in contractility. And so that drop in heart rate coincides with a dramatic decrease in the cardiac output. So cardiac output in pediatric patients is primarily driven by the heart rate. Additionally, we see some other differences as well. You can see with the pediatric circulatory system, bradycardia, as we just mentioned, is extremely bad because of the resulting decrease in cardiac output. And one of the things that's interesting is with bradycardia, we see a decrease in cardiac output that's going to cause an impaired perfusion of the body, including the coronary, the cardiac muscle, and that can cause hypoxia to develop. And that hypoxemia of the blood can then cause a reflex bradycardia. So we see this kind of cycle that develops of hypoxia causing bradycardia, which leads to more hypoxia, which leads to more bradycardia. And so that's one of the reasons that really making sure that we keep the pediatric patient's heart rate normal or slightly elevated is so crucial, and really avoid bradycardia in pediatric patients. And as well as making sure that we are especially diligent in ensuring the adequate oxygenation of pediatric patients as well. So if you look at the adult versus the pediatric circulatory systems, you can see with adults, they have a much higher resting parasympathetic nervous system tone. They're kind of slower creatures if you think of them that way. And then in hypotension with adults, we see that that's going to trigger an increase in heart rate and an increase in contractility. So we kind of see that balance. Remember that as blood pressure decreases, the heart's going to compensate. It's going to beat faster, it's going to beat stronger. As we go the opposite way with adults, if we see hypertension, then often we'll see a decrease in heart rate and a decrease in contractility. Excuse me. With pediatric patients, you can see that they have a higher resting sympathetic nervous system tone, so they're much more, you think of them as faster creatures, or much more inclined to be sympathetically innervated. We can see that with hypotension in pediatric patients, because they lack that contractility, that all we're going to see is an increase in the heart rate. Now let's move on and talk about some of the common diseases that involve the cardiovascular system. We'll look at hypertension, ischemic heart disease, myocardial infarction, and heart failure. And we'll look at each of these and kind of talk of them in more detail, specifically about how they affect the functional structured units of the cardiovascular system. So if we look at hypertension, one of the things that we see here is what does it involve? It involves the blood vessels, and then it also involves the pressure regulator kind of control mechanisms as well, specifically the kidneys and the vascular smooth muscle. If we look at ischemic heart disease, what does it primarily involve? We're looking there specifically, and it involves the coronary arteries and impairing the ability of the coronary arteries to supply adequate blood flow and then adequate oxygenation to the myocardial tissues. If we look at myocardial infarction, specifically we're looking at issues involving the coronary arteries that affect the heart muscle themselves. And then heart failure, once again, is going to involve the heart muscle as well. So one of the things that we kind of commonly see is this idea of a common progression of cardiovascular disease, where we see the beginning signs of hypertension, then atherosclerosis, which ultimately leads to, with progression, it leads to myocardial ischemia, leading to myocardial infarction. And then once we lose, once we damage the heart muscle themselves and it's replaced by scar tissue, then the heart's not able to pump as well as it normally should, and then that ultimately leads to heart failure. So let's start by talking about hypertension. When we talk about hypertension, there's two kinds, primary and secondary. We'll start by looking at primary hypertension. That accounts for about 90 to 95% of patients with hypertension. In terms of the cause, it's unknown in terms of what causes hypertension, but it has a whole bunch of factors that are associated with it, things like obesity, smoking, sedentary lifestyle, alcoholism, and certainly genetic predisposition. All these impact the likelihood that a patient can be diagnosed with primary hypertension. Secondary hypertension, on the other hand, accounts for 5 to 10% of the cases. But with secondary hypertension, there is some sort of underlying cause. Typically, it's some sort of anatomic problem that causes the patient to be hypertensive. Because of that, sometimes these can be cured or fixable with surgery or some sort of approach. Examples of this would be like renovascular disease, where maybe we've got stenosis of the renal artery, and because we've got a stenotic lesion there, that's leading to decreased blood flow to the kidneys, and the kidneys are interpreting that as global or systemic hypotension and then triggering the renin-angiotensin-aldosterone system. And so if we're able to go in and remove that stenotic lesion, then the kidney gets normal blood flow, and then the renin-angiotensin-aldosterone system is no longer being triggered like it was before. So renal vascular disease, one of the products of that is this dysfunction involving the renin-angiotensin-aldosterone system, where that system is turned on when it really should not be. Another example is some sort of problem with the endocrine system, specifically, something like a pheochromocytoma, where we get excessive release of vasopressors or catecholamines, specifically like epinephrine, from the adrenal glands. So that tumor causes excessive secretion of epinephrine, which causes hypertension and tachycardia and all the problems that we expect from excessive epinephrine release. If we're able to go in and excise the tumor or remove the offending adrenal gland, then we no longer see excessive epinephrine release and all the problems go away. In terms of risk factors for hypertension, as I mentioned, there's a variety of them. The ones that we see here: smoking, atherosclerotic plaques, inflammatory events. All of those are highlighted because they lead to damage of the inside lining of the vascular endothelium. We also see increase in age. Hypertension is much more prevalent in elderly individuals. We also see dysfunction of the autonomic and hormonal controls. These are all risk factors for hypertension. Now, as I mentioned before, there's a variety of different mechanisms, the 3 mechanisms that are involved with maintaining and regulating blood pressure. And the ones that impact hypertension, typically we see the autonomic versus hormonal regulation. Those are the 2 common areas of concern when we look at kind of trying to treat hypertension. So the autonomic nervous system, remember, is the second by second or beat by beat control, and oftentimes that's regulated by sympathetic upregulation. We see that with hypertensive patients, and so that's one of the areas that we combat by giving beta blockers. We also look at hormonal regulation, which is much more of a long-term controlled response, and so we can look at that as well. That would be where your diuretics would typically impact. So the major effect that we see in terms of these 2 systems is that they help regulate and control pressure and volume. And so it makes sense that those are the 2 main targets when you look at managing hypertension. So if we look at drug therapies, we can see a variety of different classes. Here we can see the different drug classes on the right and the targets on the left and the kind of the targets they correspond to. So obviously the kidneys and the autonomic nervous system, the renin-angiotensin-aldosterone system, those are all targets. So we can use our diuretics for our kidneys to help regulate the volume of the system. We can look at our beta blockers to help combat the excessive sympathetic upregulation. We can utilize our ACE inhibitors or angiotensin receptor blockers to help deal with the renin-angiotensin-aldosterone system effects, specifically the angiotensin component. And then we can also look at the heart and vascular smooth muscle, and the drugs that impact those, specifically in terms of the contractility, would be our calcium channel blockers. Let's talk about our diuretics. As you can see, there's a variety of diuretics. We can see our thiazide diuretics, which impact the proximal aspect of the proximal convoluted tubule. You can see the loop diuretics right below the loop of Henle. That's their main source of activity there. We can also see in the distal convoluted tubule, you can see we have osmotic diuretics once again, specifically the potassium sparing. And then we've also got additional osmotic diuretics that impact the collecting duct and the tubule. So we've got a variety of different diuretics that all have activity in different sections of the renal tubule vasculature. So our diuretics are typically the common first-line drug therapy used for hypertension. They're relatively inexpensive, and what's nice is they actually have a high degree of patient compliance. The main reason for that is because they're only given once a day. So patients, it's been proven that the more complicated the dosing schedule, the decreased return you get in terms of patient compliance. So if you give a patient a drug that only requires them to take it once a day, they're going to be much more likely to follow that than if you give them a medication where the dosing regimen requires 3 or 4 times a day dosing. Additionally, diuretics have been proven to be pretty effective in terms of managing hypertension, and they work really, really well, especially when we combine them with other antihypertensive medications, especially beta blockers. And so it's pretty common that you'll see a patient taking hydrochlorothiazide in combination with a beta blocker like metoprolol. One of the things that's kind of interesting, though, is there's actually a pretty poor correlation between the antihypertensive activity and the actual diuretic potency. We'll talk about that in a minute. So our thiazide diuretics, we'll start with those. Hydrochlorothiazide or Diuryl, that's the most common one. Typically we see HCTZ, that's the generic form. It's the most common diuretic drug class used. Its activity, as you can see here, is by the red circle. The thiazide diuretics are identified are having action on the proximal convoluted tubule. Its actual diuretic activity, which is what I was talking about before in the previous slide, is actually pretty weak. We see a mild diuretic activity with hydrochlorothiazide when we first put a patient on it, and then that kind of tapers off over time. But the activity, the antihypertensive activity part, kind of maintains. We see relatively few side effects at moderate and low doses. At higher doses of hydrochlorothiazide, we can see tolerance develop in some of the side effects. But in terms of our dental concerns with thiazide diuretics, we really don't have a lot of concerns there. Next, we'll talk about our loop diuretics. The prototypical loop diuretic that we'll talk about is furosemide or Lasix. Lasix, or furosemide, unlike hydrochlorothiazide, has a very strong diuretic activity. Next, we'll talk about the potassium-sparing diuretics. We're looking specifically at spironolactone or aldactone, and essentially what these are, they are effective competitive antagonists for aldosterone. And by blocking aldosterone, what they're able to do is inhibit the sodium-potassium pumps. They have activity in both the distal convoluted tubule and the collecting duct, and by inhibiting these sodium-potassium pumps, they're able to basically block the reabsorption of sodium, which, remember that water is going to follow the sodium molecules, and so if we prevent the reabsorption of sodium, then the sodium is going to be excreted and the water is going to go with it. So we have, the nice thing about these, though, in the potassium sparing, is that we don't see the hypokalemia concerns. Triamterene is another example. It's used in combination with a thiazide diuretic. When we look at dental concerns for our potassium-sparing diuretics, once again, kind of like our hydrochlorothiazide, we don't see a lot of dental concerns there. The next drug we'll talk about are beta blockers. These are the second most commonly used antihypertensive medications. Beta blockers reduce the workload of the cardiovascular system by essentially blocking the beta receptors and preventing the sympathetic nervous system from kind of being able to exert its clinical or site-specific actions. So what do we see with beta blockers? We expect to see from the beta blockade, specifically the beta 1 blockade, we're going to see a decrease in the heart rate, a decrease in the blood pressure because of the resulting decrease in heart rate, and a decrease in cardiac output. We're going to see a decrease in renin production as well. And one of the things that's kind of interesting is when they've looked at the effectiveness of beta blockers, all beta blockers are equally effective as antihypertensive agents. Now, that doesn't mean they all have the same dose. They all have different potency, but at equal potent doses, their antihypertensive activity is all about the same. Now, in terms of the targets for our beta blockers, where do these medications work? They work a couple different areas. The sympathetic nervous system branch of the autonomic nervous system is the main component here. That's going to affect the blood vessels. It's also going to affect the heart as well as the kidneys. We can see that beta blockers can be categorized by their cardioselectivity. So we can see here we've got our beta blockers or beta adrenergic antagonists. You can see that the first category there is the cardioselective. That would be our beta 1 selective drugs. The prototypical one there is metoprolol. Esmolol is another one that's a cardioselective beta 1 antagonist. Esmolol is kind of nice because it's got a very short duration of action, so it's commonly used during sedations and anesthesia to help lower the heart rate. And once again, it's kind of nice because the effects only last about 5 to 10 minutes. But metoprolol is certainly the most common one that you're going to see patients taking. We've got our non-selective beta blockers, and so that's going to, by definition, non-selective is going to involve blockade of our beta 1 and beta 2 receptors, which can be problematic for some particular patients, specifically if they've got concurrent asthma, and you need to give them a beta 2 antagonist. That can make things kind of difficult. The most common one there that we'll see is propranolol, not commonly used for hypertension that much anymore, but you may see patients taking propranolol because of migraines. So some of the prototypical beta blockers, as I mentioned in the previous slide, the non-selective that block beta 1 and beta 2 would be propranolol, otherwise known as Inderal. And then the cardioselective or beta 1 selective would be atenolol or metoprolol. Beta blockers have a proven track record. What's nice is, once again, the dosing schedule is typically once a day. Very rarely do I see patients on twice-a-day dosing. Beta blockers have been less effective in patients with low plasma renin activity. That would be like your African Americans or your elderly patients. But it's very effective in patients with high plasma renin activity. Those would be like your young white males. Next, we'll talk about some of the dental concerns. With beta blockers, we have a risk of hypertensive crisis. That's what we see if they're on a non-selective beta blockers and we administer epinephrine. Remember that the cause for that is the interaction between the vasoconstrictor, the epinephrine. Next, we'll talk about ACE inhibitors. ACE inhibitors have multiple mechanisms of action. The main thing that we see here is that they inhibit the conversion of renin they inhibit the renin-angiotensin-aldosterone system. Specifically, what ACE inhibitors do is they block the conversion of angiotensin 1 to angiotensin 2. Remember that angiotensin 2 is a very potent vasoconstrictor, and so by preventing the conversion of angiotensin 1 into that active form, we're preventing or minimizing the amount of the vasoactive substance being formed. ACE inhibitors also stimulate the synthesis of some vasodilating prostaglandins, and so that vasodilating activity is going to occur. Now, the main problem with ACE inhibitors is that they can cause some interesting side effects, one of those being a dry cough. Here you can see the pathway. You can see the ACE inhibitors are going to have their activity by preventing or impairing the activity of the angiotensin converting enzyme, and also inhibiting the kinaninase 2, which leads to which normally would produce inactive peptides. So ACE inhibitors, in addition to the cough that we see, some of the other side effects, you can see the dry cough occurs in about 10 to 15% of patients. When the dry cough happens, typically patients will go off their ACE inhibitors. They'll move them to a different medication like an ARB potentially. They can also have some interesting skin rashes, and this picture here is a nice picture of angoneurotic edema that can impact the lips and or the tongue, and it can be very significant swelling that has been so significant that patients have needed to be admitted to the hospital to help maintain a patent airway. So ACE inhibitors, though, are pretty effective as monotherapy. They're used as sole agents in about 40 to 50% of patients. And then they can also be combined with other drugs, especially when you have patients that don't respond to monotherapy alone. Some of the common ACE inhibitors here, you can see lisinopril or Zestoril, captopril, or enalapril. You can identify them because they have the PRIL ending on the generic name. And so they're often ideal for long-term therapy, especially as long as the patients don't exhibit any of those interesting side effects. They're not associated with any of the negative long-term side effects that are otherwise seen with your beta blockers and some of your diuretics, specifically your loop diuretics, the hypokalemia. We can look at angiotensin receptor blockers next, or ARBs. Losartan is the main one here. These are going to block the angiotensin 2 effects, and that does so by blocking the receptor that angiotensin 2 binds with. And so it doesn't really affect the angiotensin 2 levels at all, unlike your angiotensin converting enzyme inhibitors. This just blocks the receptor. So they're a little less potent than the ACE inhibitors are, but the main positive aspects of an ARB is that you still get the reduction in blood pressure without the interesting side effects. There's no cough, there's no rash, there's no reports of the angioneurotic edema. Next, we'll talk about the calcium channel blockers. Calcium channel blockers have a couple different sources of action depending on the classification of the calcium channel blocker. They act on vascular smooth muscle. They all are equally effective for managing mild to moderate hypertension, and so they can be used for patients suffering from additional forms of cardiovascular disease in addition to hypertension. Some of the calcium channel blockers also have activity on the SA node and act directly on the myocardial tissues. The two there of particular note would be diltiazem and verapamil. And so I've kind of broken them down into two general classes. There's the dihydropyridines, which are essentially vascular selective. They're going to have activity on the vascular smooth muscle and not really have any activity on the SA node or the myocardium. And you can identify those because they all end in IPINES, so things like nicardipine. Those are examples of the dihydropyridine classes. And the other two are really two other classes, but I kind of lump them together. That's verapamil and diltiazem. You can think of them as kind of being the same because they have activity on the vascular smooth muscle and also the heart. So those two have activity involving the blood vessels and the heart, whereas your dihydropyridines affect just the blood vessels. So here's a kind of a busy slide, but I want you to focus on the red circle there that identifies the dihydropyridine receptor. And by basically blocking that with the dihydropyridine, essentially what you're doing is preventing the calcium ions from flowing into the inside of the cell. And that calcium, unless it's blocked, normally would trigger the resulting processes which allow the muscle to contract. And by blocking that receptor site, the calcium is not permitted to flow into the cell and not able to have its normal triggering effects. So we lose some of that contractility, and that ultimately causes the effects of the vasodilation. Now, with calcium channel blockers, they do have some interesting side effects in terms of our dental concerns. They've been known to cause gingival hyperplasia. It's typically most commonly seen in older patients that are over the age of 50 that have been on calcium channel blocker therapy for a long time. Nifedipine is one of the more common ones. Nifedipine-induced hyperplasia tends to appear anywhere between 1 to 9 months after the kind of dosing that you see there. Verapamil is another one. It's not a dihydropyridine, but it has also been known to cause gingival hyperplasia that appears a little bit longer, about 10 to 11 months after, with doses that you can see there, 240 to 360 milligrams per day. Now, what's interesting is when the patients go off of the calcium channel therapy, the hyperplasia begins to resolve. And you can see that it can take some time. Usually you start to see the first initial signs within a week, and then it usually is completely regressed after a couple of months. Moving on, we'll talk about myocardial ischemia and angina. Now, one of the important concepts to understand when we talk about myocardial ischemia is that really what we have here, and angina is the same thing, is that really what we have is an imbalance between the supply of oxygen and the demand for oxygen, primarily involving the myocardial tissues. Now, when we have that imbalance, it can be caused by a variety of different reasons. We can have an imbalance because the heart is really working excessively hard and using more oxygen than it can get, or maybe the supply component is being impaired. So, some of the potential causes we can have coronary atherosclerosis, that's going to impair the supply part. We can have excessive adrenergic stimulation, that's certainly going to impact the demand component. We can have coronary artery spasm, coronary artery thrombosis, platelet aggregation, etc. Those are both going to impact the supply component. So it doesn't really matter. Anyway, either cause ultimately is going to lead to the same thing, where we have that imbalance between supply and demand, where the myocardial tissue is not getting the oxygen that it effectively needs. Now, this may or may not produce pain. It kind of depends on the patient. With angina, this is where we see pain associated with acute myocardial ischemia, and that will resolve with rest. Now, there's a whole different types of angina. A couple different types we'll talk about. We have angina pectoris, stable angina, unstable, and then this kind of variant or Prinzmetal angina. Now, angina pectoris is caused by acute myocardial ischemia that happens during exercise or stress. And what happens is when we overload the heart and we deprive it of oxygen, we have that chest pain. And then when we stop and kind of allow the supply to kind of catch back up with the demand, then that chest pain goes away. We can also have stable angina that's typically caused by coronary artery stenosis. And once again, we're going to see the same kind of thing with angina pectoris, where we have, if we stress the heart too much and it's not able to get the oxygen it needs, then we're going to have the chest pain. If we slow the heart rate down and kind of reestablish that imbalance or that balance between supply and demand, then the chest pain kind of goes away. We can also see unstable angina. Unstable angina is defined as either new onset or a change in the chest pain, or angina that does not resolve with rest. Typically, it follows a crescendo pattern where it tends to get worse, kind of more intense, and it can occur at rest or during exercise. And then we also have that variant or Prinzmetal angina, which is caused by coronary artery vasospasm, has nothing to do with exercise or not, and it is only relieved when we break that vasospasm. So we can see the different drug therapies for the different types of angina. So angina pectoris, typically patients are on nitrates. They'll be carrying around little nitrate tablets with a spray. They have the chest pain, they take the nitrates, it causes vasodilation, relieves the chest pain, and then they go back to normal. With stable angina, they can be on beta blockers, calcium channel blockers, or longer lasting nitrates. Unstable angina is kind of a special one. That's where we look at, unstable angina is kind of also known as a suspected myocardial infarction. And need to be treated accordingly. That's where our mono protocol is going to come into play. Here you can see some of the drugs, the aspirin, the nitrates, the morphine, and also oxygen would be on there as well. And then that variant, the Prinzmetal angina, which is once again caused by the coronary artery vasospasm. The way to break that is with the calcium channel blockers. The nitrates they're not effective with Prinzmetal's angina. So some of the drug therapy for unstable angina, as I mentioned before, that's where our mono protocol comes into play. The nitroglycerin, what is it going to do? It's going to act directly on the vascular smooth muscle, the vascular endothelium to dilate the smooth muscle. And so it has a lot of effects both with the systemic veins and the arteries. And you can see that by dilating the medium and large coronary arteries, we're going to reestablish the oxygen supply and help alleviate the lack of oxygen being delivered to the myocardial tissue. What does the morphine do for an unstable angina patient? The morphine has kind of an interesting effect. It has two things. Number one, it acts as an opioid agonist, and so it's going to help reduce the pain, the chest pain, the intensity of it. It's going to also help reduce the sympathetic tone, which will help take care of reduce some of the oxygen demand. Morphine is rather interesting in its own right in that it also has a secondary activity in that it causes histamine release, and that histamine release can be useful because it helps promote vasodilation of the coronary blood vessels, which once again is going to help increase the oxygen supply. So both of these medications help reduce symptoms by promoting vasodilation. What about aspirin? Aspirin is going to be used during unstable angina or suspected MI. The main effect that we see here is that it's going to help inhibit thromboxane release from platelets. Remember that thromboxane A2 is part of the arachidonic acid cascade, and it is an extremely potent vasoconstrictor, and it also helps promote platelet aggregation. And so by inhibiting thromboxane A2 production, we're going to inhibit the potent vasoconstrictive component, and we're also going to help make those platelets a little less sticky to help minimize the thrombosis from forming or getting larger. So when we look at drug therapy, specifically aspirin, aspirin has been shown to decrease mortality and it has been shown to decrease the progression. So it helps prevent or further worsen the movement of an unstable angina patient to a suspected MI. Now in the acute or in the dental setting with acute angina, how are we going to manage this? Well, what we need to do first is make sure that we stop the treatment, and we're going to get the patient nice and comfortable. We're going to provide them with extra oxygen, so either a nasal cannula or a full face mask. And then you're going to go ahead and consider administering your nitroglycerin. Now, I have a picture here of the nitroglycerin spray. I prefer the nitroglycerin spray for a couple different reasons versus the tablets. Number one, the spray has a much longer shelf life. It is more expensive, but it has a much longer shelf life. And additionally, once it's open, you can use it on multiple patients. You just need to wipe off the spray nozzle with disinfectant. And so you would apply 1 to 2 sprays every 3 to 5 minutes until we see an effect. The onset should be rather rapid. It's going to be sprayed sublingually. The onset should be about 1 to 2 minutes. Now, if we have the drug therapy for the Prinzmetal's angina, once again, the Prinzmetal's angina involves the vasospasm of the coronary arteries. And so because of that, we really need to look at our calcium channel blockers. So our nitrates may or may not be effective. Typically, they're not so effective, but certainly you could consider using them. The other issue there is it really has nothing to do with the increase in sympathetic tone or platelet aggregation. So our beta blockers and our aspirin are not going to be helpful. The main underlying problem here is that vasospasm that occurs, and so that's why we need to utilize our dihydropyridines. Now, that's not something that you're going to do in the dental office. You could certainly consider the nitroglycerin spray and then referral to the emergency room, and they would manage it from there. Next, let's talk about myocardial infarction. So with an infarction, what we have is ultimately necrosis of the myocardial tissue, and that's a result of the sustained persistent ischemia. So the lack of oxygen leads to, first of all, cell injury, myocardial injury, and then ultimately myocardial death. And then that tissue, once it dies, is replaced by fibrous connective tissue. Now, that fibrous connective tissue does not have the contractility of the normal myocardial tissue, so it can't participate in the the squeezing pumping function of the heart. Additionally, that connective tissue does not have any sort of it is not able to conduct the electrical current like the normal myocardial tissue can. And so it effectively creates a black zone where that electrical conduction can't penetrate and actually it kind of has to go around it. And so it's one of the leading causes of lethal cardiac arrhythmias. And here you can see a nice picture that shows the time of onset. We have the ischemia that after 20 to 30 minutes, now we start to see a thin line of infarction, cell death. It just effectively kind of gets worse and worse and worse without intervention. So with myocardial infarction, the morbidity and mortality can be limited if we are able to promptly get them treatment and therapy right away. And so survivors are at significant risk for reinfarction for the first 6 months following the initial MI. In terms of implications for dental therapy for a patient that has an acute MI, what do we need to do? Well, the first thing we need to do is stop treatment, and then we need to look at what are the goals of the drug therapy and what drugs should be kept on hand for management of the suspected acute MI. Now, in terms of the post-MI, what are the questions that we have? We want to know what drugs will the patient be on or likely be maintained on, and then when is it safe to undertake dental treatment, and what precautions do I need to consider? We'll talk about each of these. All right, so if we look at an acute MI, what are our goals of drug therapy? Well, the first thing we need to do is minimize the loss of the myocardium. We need to essentially get them, evaluated in the hospital as quickly as possible, and we need to make sure that we can do everything we can to prevent any sort of ischemia-induced arrhythmia. And so the drugs that we use, this is where our MONA protocol is going to be enacted. So our MONA stands for morphine, oxygen, nitroglycerin, and aspirin. These are the frontline therapies that you should have on hand in your dental office. Now, you may or may not have morphine, but you're probably, and you should have oxygen, nitroglycerin, and aspirin. All right, and so if you have them on hand, this is where you would initiate that protocol. Now, as I mentioned before, you may or may not have morphine, but you're probably going to have some sort of monitors. So you can go ahead and put a pulse oximeter and a blood pressure cuff on. Obviously, the first thing you want to do is if you've got a patient who is complaining of chest pain and you think it may potentially be having a heart attack, the first thing you want to do is notify 911, and then once you've notified them, then you can go ahead and place your monitors, give them oxygen, add the nitroglycerin or nitrous oxide as tolerated. The nitrous oxide can be used that it's also going to provide some degree of analgesia, which can help reduce the sympathetic tone, and it may promote a little bit of vasodilation. You're going to go ahead and administer the aspirin as well. You can see the dose is 324 milligrams, and that's crushed up, like chewed up in the mouth at the onset of symptoms as indicated. Now, in terms of management at the hospital, one of the things that the hospital will consider is pharmacologic reperfusion. They can consider administering TPA, which is known as tissue plasminogen activator. That's a clot buster. It's a medication that's administered to break up any sort of blood clot. It's the same thing that's used for a stroke, for an occlusive stroke. And it can induce a breakup of that clot in about 60 to 90% of the patients. But the key here is that they have to be treated and identified and treated very, very early. Typically, the window is within the first 6 hours. Now, that reperfusion will help normalize coronary blood flow in about 30 to 60% of the infarcted related arteries. And you'll see a 50% reduction of mortality if they can be identified and treated within the first hour. So this is something that you certainly do not want to sit on, and it's especially important that you notify 911 and get help get help on the way as early as possible. And so we can see up to a 50% reduction in the size of the infarct as well with early therapy. So it does two things. It not only reestablishes blood flow early, which will help decrease the mortality, but also help decrease the overall impact of the size of the infarcted tissue. Now, in addition to pharmacologic therapy, they may consider surgical or invasive reperfusion therapy as well. The goal there, once again, is to regain or reestablish blood flow to the infarcted tissue to help minimize the damage of the myocardial tissue there and loss of the damage. And this can be done a variety of different ways. It can be done via coronary artery bypass graft or an angioplasty, where they go in with a balloon and kind of stent open or pop open the atherosclerotic blood vessel. They can also consider placing a cardiac stent, and there's two different kinds. There's the bare metal or the drug-eluting stent. So those are some of the different options that they have at hand. In terms of drug therapy for the post-myocardial infarction patient, in the first 6 months, what do you expect them to be on? You expect them to be on a beta blocker to help minimize the control of the heart rate and the sympathetic nervous system tone. So that's going to decrease the the demand component for the heart, basically make the heart relax. We'll also expect them to be on usually some sort of anticoagulant therapy, and that's going to help prevent any sort of thrombus formation. You're going to expect them to also be on blood pressure medications as well, either calcium channel blockers or ACE inhibitors or diuretics. So we're going to expect them to be on those medications. You're also going to be instructed to avoid epinephrine for some period of time. Usually within that 6-month window, you're looking at emergency dental procedures are really what we're kind of restrict our dental procedures to. If you do have to treat a patient and they're stable, but within that window, you want to make sure that you minimize your epinephrine. We're looking at 0.04 milligrams per dental visit. So, 1 to 200,000 or 1 to 100,000 concentration of epinephrine. You're looking at 2 cartridges and that's it. All right, thank you for listening. If there's any questions, please contact me via email. Thank you.